Hello, everyone, and welcome to What's New with the Flu for Urgent and Convenient Care Clinicians. I'm your moderator, Rachel Deere with DAB Med. Thank you so much for joining us today. This activity is supported by an educational grant from Genentech, a member of the Roche Group. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters. Here are our learning objectives for the day. Describe indications of antiviral medications that prevent and treat influenza. Assess the benefits of antiviral medications for prevention and treatment of influenza, particularly for children. And describe the effects of inappropriate antibiotic prescribing and strategies to reduce this overuse. Okay, I am joined by our wonderful faculty, Dr. Paul Auwaerter and Dr. Mark Watkins. Thank you both so much for being here.
Yeah, good evening and good afternoon. Glad you could all make it.
Yeah, good evening. Nice to be here.
Wonderful. And thank you all for joining us today. All right, and here are our faculty disclosures. And before I hand things over to Dr. Auwaerter, we have a pretest for all of you, and you will see a poll pop up. So let's push that to all of you now. You should be seeing it. And you'll see, we'll revisit these questions towards the very end of the presentation, so you'll see these again. So let's see. All right, question one, and this is kind of a long question, long case, so I will read it out loud. In January, COVID and influenza are circulating in the community, but RSV had its seasonal peak in the fall. Marco, a 54-year-old man, visits an urgent care center 3 days after abrupt onset of myalgia, fever, nasal congestion, headache, and cough. Marco currently has a temperature of 101.1 degrees Fahrenheit. His blood pressure is normal, respiration is unlabored, and lung exam reveals no crackles or wheezing. He has type 2 diabetes, which was diagnosed 7 years ago, and takes metformin. He reports that his A1C was 7.1% at his last visit to his primary care provider. Marco reports that the rapid COVID test he took at home this morning was negative. He has no other known comorbidities. He did not receive a flu vaccine this year. So here is the question for all of you. Is an influenza antiviral recommended for him, and why? A, no, it's not recommended as more than 48 hours have elapsed since symptom onset. B, it's recommended if influenza is confirmed by molecular test. C, recommended since he has not received a current vaccine for flu. Or D, recommended as high-risk condition for severe influenza. I'll give everyone a moment to answer that. And again, we will revisit this at the end of the presentation. Okay, and we've got another question, which you should all be seeing now. This one's a little bit shorter. Question 2 is 68-year-old woman who is confirmed to have influenza visits your urgent care center. She has brought her 4-year-old grandchild with her. The child has asthma, has been hospitalized thrice this year, and has not received a flu vaccine yet. In addition to recommending the flu vaccine, which of the following would be recommended for the A, baloxavir, B, oseltamivir, C, pramivir, or D, zanamivir? Give everyone a moment to answer that question. Okay, wonderful. And before I hand it over to Dr. Auwaerter, who's going to talk about indications for antiviral medications, I do have a couple more questions for all of you. So let's get to those. These are a little bit different. These are set up as 2 truths and a lie. So you should be seeing the questions pop up. So there are 3 statements here. 2 are true and 1 is false. So please spot the lie. And we'll revisit these questions at the end of each section. So, statement A is a 6-year-old Korean American child is at a higher risk of severe illness with the flu. B, a 21-year-old Black man is at a higher risk of severe illness with the flu. Or C, a 55-year-old Hispanic woman is at higher risk of severe illness with the flu. Give everyone a moment to answer that question. And again, 2 are true, 1 is false. So spot that lie, spot that false statement. Okay, now I will turn things over to Dr. Auwaerter.
Okay, thanks so much, Rachel. And I think for many of us, and I do some primary care myself, if you're on the front lines of evaluating people with respiratory illness, it's really a toss up as to what might be affecting your patient. And things have certainly gotten more complicated following the pandemic, as we now have, I would call, the big three circulating viruses here. And there's really not anything that can be especially distinguishing, but it's important, I think, to always pay some attention to what's circulating in your communities to make some judgment about how you might proceed and whether you wish to further evaluate and treat your patients. I think, though, a couple of things are notable if we look at the clinical spectrum of these frequent respiratory causes of illness. Uh, Influenza certainly continues to be more of an abrupt illness in many patients, but not all, where people, of course, get very flu-like sensations rather dramatically, often in a space of hours. And the people at greatest risk are really children under 5, especially under 2, and then also older adults. And of course, not only respiratory symptoms, but sometimes with abdominal issues as well. The same is true for SARS-CoV-2 infection. And especially now that most people, almost everyone has background immunity to some degree, it certainly has more of a gradual onset for most. Again, a little different here is children, at least healthy children, tend not to be especially troubled except for infants. And we'll go over risk factors shortly, but there's often an overlap amongst all these three viruses as to who has the potential for really serious illness. Now, RSV has always traditionally been thought of as a pediatric problem, mostly for people under 2, but certainly in recent years, come to be appreciated that it's probably the 3rd leading cause of serious respiratory illness and hospitalization of viral nature in older adults. And there's not too much here that can distinguish. So often if you have the ability to test, that can help really direct your therapy. Although obviously RSV often peaks earlier in the fall, but and influenza has come back in force now that social mitigations have decreased. Now, last year, I think we really came to attention that influenza became back with a pretty serious set of problems for us. In addition to the substantial burden of COVID, there were many infections and hospitalizations and 20,000 deaths. To give you an idea, totally, the usual range is 12 to up to 60 plus thousand deaths that are estimated every year for influenza. So this was a mild to moderate year in terms of influenza-related deaths. But importantly, the ones that are reported are the pediatric deaths, and there were 174. And that's, again, one of the highest levels that have been seen. And I think some of that may be because, of course, with influenza disappearing for a couple of years, especially children didn't have a lot of background immunity if they hadn't gotten immunizations. Now, influenza itself, of course, advocate for immunization for nearly everyone 6 months of age or older, and that remains a very important primary prevention. Now that we're even in January, it's still advocated if people haven't been immunized to go ahead and give it to them. We have a lot of circulating influenza right now in January in most parts of the country. And the second is there's been a return to suggestions of masking, especially in healthcare environments, also for those that might be at high risk for consideration right now. And so those are just fundamental points that, especially for patients that might be at high risk for complications, to consider. But now let's focus a little bit on therapies for influenza. That's what this program is about. And unless you've been practicing more than 13 or 14 years ago, the bottom row of amantadine and rimantadine have not been used since the 2008-2007 influenza season, when there was actually a substantial amount of circulating oseltamivir-resistant virus that year. But ever since that time, those have not been favored, and circulating virus appear to be resistant. So we're really left with two classes. That's the neuraminidase inhibitors in the middle column there. And then on the top column is a newer agent, baloxavir. That's a cap-dependent endonuclease inhibitor. And we'll talk about those in a moment. But importantly, all these agents that are currently recommended treat both influenza A and B. Now, the neuraminidase inhibitors is just a very brief primer. I think it's important when you think about an antiviral, it's not like an antibacterial agent where you're killing bacteria. All you're doing with an antiviral is really inhibiting the production of additional virus. So this is not really trying to staunch or reverse a virus that have already been made, but instead just preventing the production of new virus. And where the neuraminidase inhibitors work are all the way at the end of the virus life cycle, because it inhibits with the necessary enzyme that is important for a virus to cleave off and bud from a host cell at this stage. So it's really at the end of the virus life cycle. And one of the reasons why, especially for neuraminidase inhibitors, early treatment is very important. Now, I wanted to just contrast that with baloxavir. This is a drug that was FDA approved in 2019 and works differently earlier in the viral life cycle by inhibiting the production of mRNA. And so therefore, proteins necessary for assembling a new virus are not made. So you're interrupting an earlier step in the viral life cycle. And for that reason, you'll see maybe more effective in some settings for producing new virus. Now, in terms of antiviral treatments for influenza, the way how I think of it is that influenza can certainly cause serious illness, especially in people with risk factors. So what this means is if someone is hospitalized and you suspect influenza, you certainly may wish to administer the drug. But here, if you're in an ambulatory setting, the idea is that you can do a risk analysis and try to sort out, one, does this patient have influenza? And two, if the patient is presenting to you early, then there's a greater chance that anti-influenza therapy may help either shorten the duration of illness or help prevent complications, including a severe or progressive illness. Now, for people who have uncomplicated influenza, meaning they don't have any special risk factors, and that's how the FDA has approved these antiviral drugs. The thought is it really has to be given in the first 48 hours of illness to shorten the duration of illness. But that is not the recommendation for people that have risk factors, where you might even give the drug after 48 hours. Now, who is at risk for higher chances of complications? I think many of us who have become familiar with risk factors for SARS-CoV-2 we'll find substantial overlap here with influenza. But I'd point out a couple of things here that are probably important. First, the people by age range are especially under 5 years, but certainly under 2 years, and then seniors 65 and older. Also, we learned in the 2009 pandemic that people who had morbid obesity with a BMI more than 40 were at increased risk. And then of course, pregnancy is another factor that sometimes is not always immediately considered. But the rest of them, I think you can see the kind of standard comorbidities that might be in many adult patients, as well as occasional children. Now, at the bottom, what you'll see are more socioeconomic factors that may have to deal with access to care, where non-Hispanic, Black, Hispanics, Latinx, Native American Indians, and Alaskan Natives all seem to have higher risk for developing severe influenza, as well as hospitalizations. So another important category that's not truly dependent on some kind of predisposition of the host. So let's start with the neuraminidase inhibitors, which have been around for decades now. And you're probably most familiar with oseltamivir. But these are clearly more effective when they're started early. Remember, we're not killing the virus, we're preventing new virus production that can then go on and infect more cells and perhaps cause more immune stimulus in the patient. So the earlier use of it will lead to a less viral burden and therefore perhaps a shorter duration of illness in people that are otherwise healthy with uncomplicated influenza. Now, the CDC has come out and recommended a test to treat, mainly because we're dealing with influenza and COVID at the same time. So if you have capabilities that can help distinguish for many patients as to which path you may need to go to. And if we look at some of the trials for oseltamivir, and these are giving you a sense for when the drug is administered. This is an oral drug. And you can see the later it's given, you'll see less of a benefit in terms of reduction of illness, although some of the data is mixed. But what I'd point to are some of the AOKI studies that were done in Western Canada. And there, people were actually diagnosed very quickly after onset of symptoms. And you can see there the substantial reduction in the number of days, which then just speaks to the fact that if you can start the drug very early, you can really abbreviate the symptoms. Now, where people may not have as much response are those that might already have significant comorbidities, such as elderly and high-risk patients there, and especially if you're starting later after the onset of symptoms. So for patients that have severe influenza, those that you might be heading to the hospital, or you're very, you're worried and they may not be ill enough to put in hospital, but you're definitely nervous, it still is most beneficial to try to start them on the drug early. However, even up to days 3 and 4 after onset of illness, there may be some benefit. This mainly comes from observational trial information that suggests that there may be some decreased risk of progressing to having complications such as pneumonia or hospitalization, or failure to improve after a week of illness. So because these drugs are relatively benign, those that are at high risk or with severe influenza, there's still a suggestion to give the drug, even if you're beyond that 48-hour rule. And so this is just something that I think is a message that's sort of lost. We don't have great randomized controlled trials to show benefit, but I think there's not much to lose by giving the drug on the chance that it might provide some benefit from your patients if they're less than 5 days of illness, but with significant risks for influenza progression and illness. Now, I would like to just briefly touch on baloxavir because it's the newer drug. And of course, this then was compared not only to placebo, but you'll also see later to the neuraminidase inhibitor oseltamivir. And so Fred Hayden published this pivotal trial, which led to FDA approval, called Capstone 1, which is a phase 3 trial done in uncomplicated healthy adults. And the primary endpoint was time to alleviation of symptoms in the middle area. You can see it led to about a 1-day reduction. It started within 48 hours. And on the left-hand side, you'll see there is a substantial reduction in viral shedding, which may have some benefit in terms of potentially leading to less infections in households and so on. So that led to the FDA approval. And that same study also had an arm where it was compared to oseltamivir, and it performed as well as oseltamivir, as you can see in the right-hand side. The difference was, though, that this drug did have more decrease in viral shedding. And again, this has to do with the mechanism of action of this drug because it works much earlier in the viral life cycle, not at the end in the budding. And this is why it is thought that viral shedding is decreased on a much more substantial basis than with oseltamivir. Now, the number of side effects between the two drugs were very similar, as you can see in the text on the right-hand side. And we'll talk a little bit more about the drug in that context. Although that was the uncomplicated influenza study, honestly, I found this study by Mike Eisen, who was a PI out of Northwestern, published in The Lancet, a much more reflective of the kind of patients that I worry about. This is the first RCT that dealt with patients at high risk for progression to severe influenza. And so this study was over 1,000 patients. And again, the time of illness to improvement was its main point. And you can see that if compared to placebo, again, baloxavir led to about a 1-day improvement in terms of duration of symptoms. And this was true also with influenza A, which H3N2 tends to be the more serious illness, but also influenza B as well. And the rates of complications were much lower. You can see 10% compared to 2.8% overall in those that did get the antibiotics. So this looked very favorably for the drug impact. Now, when you looked at the same patient population, it was a 3-arm study, and looked at the arms that compared baloxavir to oseltamivir, interestingly, the time to improvement was a little bit better, but not statistically significant with the baloxavir. If you look at the right-hand columns, on the left hand, interestingly, that was a big influenza B year when this drug was studied. And this drug, baloxavir, remember B for influenza B, performed better than oseltamivir against influenza B for reasons that aren't absolutely clear. And again, you saw that viral shedding was markedly shorter compared to baloxavir by about 48 hours. The drug has been studied in children. So initially, the drug was FDA approved in adolescents and adults. And this trial, the Ministone 2, looked at children. Again, a very similar strategy, although this the data here shows baloxavir versus oseltamivir, very similar endpoints, but again, with a somewhat improved time in terms of total viral shedding. And because of this, a little over a year and a half ago, the FDA did approve baloxavir for use in the pediatric population 5 and older. So looking at baloxavir, the studies were all done with people with early symptoms, 48 hours or less administration of the drug, and led to about a 1-day improvement compared to placebo in a healthy population of children and adults, and then also had a reduction in viral load. And some of these studies also had fewer adverse reactions then oseltamivir, which we'll talk a little bit about again shortly. So to repeat a little bit, we were looking at the 48 hours for all these randomized controlled trials. That's how the FDA approved the drug. But if someone's beyond 48 hours, what I would say is consider still using the drug if anyone's hospitalized, if you feel they have severe or progressive illness, or they fit into some of those high risk categories. And certainly pregnant people are another one that's especially emphasized. So this just might expand some of the range of timings that you may typically have considered previously for the use of influenza antivirals. And so in patients with high risk of severe influenza, these are just some data here that helps organize what the literature, which is very extensive, especially with the neuraminidase inhibitors. And I already spoke to some of these about the observational data and some meta-analyses that have no clear survival benefit, but may show some reduced hospitalization risk and other complications. And then for Baloxavir, the Capstone 2 trial that did show some improvement compared to placebo, and then also had the lower complication with use of that drug and also need for additional antibiotics. So if you look at the CDC antiviral recommendations for Baloxavir, the key point here is this drug is a single dose. You take one dose, and so for patients that may not be good at compliance, especially for pediatric patients, this might be ideal. It is weight-based, so that's an important consideration, and it is available in oral suspension. For oseltamivir, you're probably more familiar with that drug, and it is in a capsule or oral suspension with children having weight-based dosing. Peramivir is used rarely. It's actually only FDA approved for outpatient uncomplicated influenza. I think we stock it in the hospital mainly for patients that can't take pills. And so that's parenteral, but rarely used in the ambulatory setting, if at all. And zanamivir, again, a less employed drug that's inhaled, and this is an inhibitor, but is not used for anyone that may have asthma or significant respiratory chronic illness in that case, because you do not wish to exacerbate that with a dry powder inhaler. In terms of safety, Baloxavir generally looked very good and similar to placebo in trials, whereas oseltamivir typically has 10 to up to 20% of patients reporting some GI upset and much less common other reactions. And then I already mentioned zanamivir has the risk of bronchospasm, so you definitely don't want to use that in anyone with underlying asthma. In terms of resistance, we've been blessed because the neuraminidase inhibitors and Baloxavir so far have only seen very low levels of resistance, but this continues to be monitored regularly. And I already mentioned the amantadine class is not currently recommended. So now, Rachel, it's back to you.
Thank you, Dr. Auwaerter. Okay, so we've got the same question again. So spot the lies. So let's push that to all of you. You should be seeing the poll. So again, which is the incorrect statement? What is the lie? A 6-year-old Korean American child is at a higher risk of severe illness with the flu. B, a 21-year-old Black man is at a higher risk of severe illness with the flu. Or C, a 55-year-old Hispanic woman is at higher risk of severe illness with the flu. Give everyone a moment to answer that, and then I will show the results. And as you're answering, just a reminder, feel free to submit any questions for our Q&A segment. We've already gotten some in, and we will get to as many as time allows. at the end of the presentation. And I know some of you are wondering if you will receive a copy of the slides. You will. It will be emailed to you along with the evaluation, and that way you'll be able to claim your CEV credit. Just make sure you are logged into your DKB Med account. Okay. So let's see how we did before. Okay, we're a little split. So the majority, but it's pretty close. About 37% of you said a 55-year-old did C, Hispanic woman. And let's see how you did post. Okay, interesting. The majority of you, about 60%, said choice A, a 6-year-old Korean American child. Dr. Auwaerter, what is the correct answer?
Yeah, so I think the 60% had it right. Remember, it's children under 5 and over 65 that, at least by ages, are at risk. But Asian Americans are not at any special risk. And this gets to those socioeconomic risk factors that we spoke about for severe illness. And certainly, Black and Hispanic populations seem to be at increased risk, which is why there's still a recommendation to consider that as something when you're evaluating your patients.
Thanks, Dr. Auwaerter. Okay, and before we move over to your next section, which is antiviral as chemoprophylaxis, we have another question for all of you. It is a two truths and a lie again, so I think we're all familiar with this question. So I will read it aloud, and again, we'll revisit this at the end of the section. So spot the lie. When used for prevention, oseltamivir is given once daily for 7 days. B, when used for prevention, baloxavir is given once daily for 3 days. Or C, when used for prevention, zanamivir is used once daily for 7 days. Give everyone a moment to answer that. Okay, now Dr. Auwaerter will take it from here.
Okay. All right. Well, thank you so much again, Rachel. So, for patients, of course, they should be immunized, but those that are not, or perhaps won't respond well to immunization, people that might be with B cell disorder, perhaps on drugs such as rituximab, where can't generate good antibody levels, uh, antiviral chemoprophylaxis might be given a consideration to those that are exposed, for example, in households where there might be documented influenza. So in those cases, it's recommended to start within 48 hours. And neuraminidase inhibitors are 70, 90% protective in a number of studies. And Loxavir is much the same range at 86% in terms of prevention. So it's just something to think about if you have a high risk patient, a transplant patient, someone that might be on rituximab, and perhaps their grandchild has influenza and visits, and then the next day comes down with influenza. This may be something to consider along with patients that may not have yet been immunized. So what are some of those high-risk environments? Some we just mentioned could be people that work in schools or daycare centers, and especially the advanced elderly, immunocompromised, and the very young. So I mentioned oseltamivir, which is 70, 90% protective if you can give it within 48 hours of contact. And baloxavir was also studied in the Blockstone trial here, where if there was nothing given, you can see that about a little over 13% of people developed influenza, but that was substantially lowered to just under 2%. So this was clinically significant, and because of this, the data presented to the FDA also approved it for prophylaxis indication. So looking at prophylaxis, again, it's a single dose for baloxavir, whereas oseltamivir is a 7-day duration, and the same as if you choose to use the inhaled zanamivir, again for 7 days after exposure. The differences are oseltamivir can be given to anyone 3 months or older, baloxavir 5 years or older, and then same with zanamivir. So it's either a 1 pill versus 7 days of therapy. Okay, Rachel, we're back to you.
Thanks, Dr. Auwaerter. Okay, so that was a brief segment that we had, and then we'll move over to Dr. Watkins. But before we do that, spot that lie. So you saw this a few moments ago. So let us administer this poll. Okay, again, choice A, when used for prevention, oseltamivir is given once daily for 7 days. B, when used for prevention, baloxavir is given once daily for 3 days. Or C, when used for prevention, zanamivir is used once daily for 7 days. And we will look at how you did before and after. Again, you're looking for the lie, the incorrect statement. Okay, so let's see how you all did in the pre. So the majority of you, about 58%, said choice B, which is the baloxavir given once daily for 3 days. And let's see how we did post. A pretty big increase, about 86% said choice B. Dr. Auwaerter, what is the lie?
Yeah, so the lie is definitely the baloxavir. Remember, whenever you prescribe this, it's given as a single dose, just 1 dose. So B is the lie. So people got that right.
Yeah, definitely paying attention. Great. And you will get a 30-day survey. So we hope to see that 100% of you gets that right in about a month. So before I turn it over to Dr. Watkins, we have another question. And Dr. Watkins will be talking about antibiotic overuse and how to avoid it. So here is another lie question. I promise this is the last one like this. So let's go to that poll. You all should be seeing it now. So spot the lie, the incorrect statement. A, about 20% of patients with acute respiratory infections during flu season received an antibiotic prescription. B, over 2.8 million people have affected by antibiotic resistant infections in the US each year. Or C, antibiotic resistant infections lead to at least 35,000 deaths per year in the United States. Give everyone a moment to answer that question. And we'll revisit this at the end of Dr. Watkins' presentation. And again, please submit your questions in the Q&A and we'll get to as many as time allows. Okay, I will now turn it over to Dr. Watkins.
Well, thank you, Rachel, and good evening to everyone. And it's such a pleasure to hear from Dr. Auwaerter. What a treat. So as we talk about overuse of antibiotics, the World Health Organization lists antimicrobial resistance as a top 10 threat to global health. Just let that sink in for a minute. Of all the things that we deal with, just to think that this overprescription of antibiotics can be one of the issues that we have when it comes to a top 10 threat to global health. Roughly half of all antibiotics prescribed in the U.S. are for these viral respiratory tract infections. Inappropriate use of antibiotics can cause some significant issues. So those that are working in hospital situations or not in the ambulatory setting, but we'll see a lot of C. diff infections or C. difficile infections. And then it also has a tremendous impact on the total cost of care. Over 2.8 million people are affected by antibiotic-resistant infection in the U.S., which leads to about 35,000 deaths annually. So that's just not an insignificant number. So identifying high volume prescribers. So reviewing Medicare Part D data back in 2019, we saw almost 60 million antibiotic prescriptions written. Those were written by the top 10 prescribers who wrote a median of about 284 prescriptions. Family practice internal medicine had higher volume prescribers and accounted for 60% of antibiotics prescribed. That makes a lot of sense as they make up the bulk of our clinicians in the country. And then we look at the review of U.S. claims data set with about 400 and actually 42 million primary care visits. 2% of clinicians prescribe antibiotics in 50% of visits. And so these were folks who saw mostly adults, and we saw some increase in urgent care clinicians in the South prescribing a higher volume of antibiotics. Antibiotic overuse for respiratory infections. So in this example here, we had about 15,000 patients with acute respiratory infections during influenza season. 41% were prescribed an antibiotic. Among those with confirmed influenza, this was astounding to me when we were going through this. I thought this was a typo actually when I first read this slide, that even though you have a confirmed influenza case, 29% were still prescribed an antibiotic. So understanding how important it is to make that distinction if you have a positive test, understanding that these antibiotics are largely ineffective for influenza. Less than a third of the patients with laboratory confirmed influenza were given the clinical diagnosis of influenza. So again, a little bit mind-boggling, but this still happens. So understanding that if you have this diagnosis on the chart and you actually have a positive influenza case, that an antibiotic is inappropriate for that patient. This is a little bit of a busy slide, but it really shows the proportion of children with an acute respiratory illness that were prescribed an antibiotic. And you kind of just let your eyes move from left to right. So we know that pneumonia, especially bacterial pneumonia, can be treated with and should be treated with an antibiotic. But then you have these tier 2 types of ARIs, pharyngitis, sinusitis, otitis media, and then further moving on to the right are the viral URIs, bronchitis, allergies, and some asthma. Those are antibiotics are never indicated. So obviously understanding that there's an opportunity here to ensure that you are prescribing the right medication, the right therapeutic for your patients. This one tells the same story. This one is the proportion of adults that have an ARI who get an antibiotic. And as you can see, it often mirrors what happens in the children's population, right? So again, a little bit better, but not anywhere near what we would expect. The thing I was still amazed at when you look at tier 3, where antibiotics are not indicated, especially for things like bronchitis and a clinical influenza case that is diagnosed by laboratory or sometimes a point of care test. The folks are still prescribing, unfortunately, an antibiotic in those cases. When we look at antibiotic overuse for acute respiratory illnesses by setting, some of the administrative claims studies suggest looking at about 2.7 million cases, right, of these visits that happen annually. 58,000 were at retail clinics, about 148.5 million in medical office, that we saw antibiotic prescriptions linked to 39% of the visits, specifically to urgent care, and 36 of the visits to retail clinics. So you can think about this as a little bit more than a third of the time antibiotics were being prescribed at these locations. And for influenza, 12.8% of urgent care visits resulted in antibiotic prescriptions. And we saw that kind of play itself out in the previous slides, compared with 3.8% for retail health and 7.9% for emergency departments and 11.4% for medical office visits, which leads us to believe that if you have the ability to test, like Dr. Auwaerter was suggesting or mentioned early on from the treatment strategy outlined by the CDC with the the amount of COVID-19 or SARS-CoV-2 circulating, that you kind of take that off the table and actually get a test. And to the right side of this slide, you can kind of see the proportions of where this is happening. So, the vast majority of people are likely being seen in places like a medical office. There's low ability, or actually you're seeing only about 4% of the time that an antibiotic prescription is written for in a retail clinic for influenza. So antibiotic, or actually antibacterials, are almost always indicated for the conditions to the right, like a urinary tract infection, bacterial infections like tuberculosis and pneumonia. We know that antibacterials may be indicated for pharyngitis, sinusitis, and the acute otitis media. We also are pretty confident, and I'll talk a little bit more about strategies towards the end of the presentation about how to eliminate inappropriate antibiotic use in your practice and in your treatment regimens. So things like asthma, allergy, bronchitis, bronchiolitis, influenza, these are cases where antibiotics should never be prescribed. And so these are great opportunities and learning opportunities for us moving forward. So I did mention a little bit about antibiotic stewardship, and this has really been advocated by many across the clinical spectrum, to include the CDC, but you want to be able to measure the amount of antibiotics in your practice that you're prescribing, improve the ability of the clinicians to prescribe the medications that are best for their patients, and that antibiotics are only prescribed and used when needed, minimize misdiagnosis or delayed diagnosis, meaning that if you have the ability to test and it's the right opportunity from a medical decision standpoint, go ahead and understand the diagnosis completely and ensure that the right drug, dose, and duration are selected when the antibiotic is needed. And that's very, very important to help really be a good prescribers and to stay in line with appropriate antibiotic stewardship. The core elements of outpatient antibiotic stewardship, and a lot of this can be out, you can see it right there on the CDC's website. Make a commitment, demonstrate dedication and accountability to optimizing when to use antibiotics. Number two, action for policy and practice. Implement at least one practice or one clinic to improve antibiotic prescribing. Do you use evidence-based diagnostic criteria and treatment recommendations? And we'll talk about this a little bit later as well. Do you use delayed prescribing or watchful waiting when appropriate, right? Especially for those tier 3 opportunities around viral URIs and those types of conditions. Tracking and reporting. Monitor at least one aspect of antibiotic prescribing. Do you self-evaluate antibiotic prescriptions in your practice? CMEs and quality initiative activities to track and improve provider prescribing can be helpful in understanding the impact of the antibiotic stewardship program in your setting. Education and expertise. Educate patients and seek out continuing education on antibiotic prescribing. And this is really self-explanatory. Things like, do you provide patient education material? Do you educate your patients about the potential harms of antibiotic treatment? And then do you use effective communication strategies to educate patients about when antibiotics are not needed? And I think that's an important consideration. And we'll dive a little bit deeper into that, because having those conversations during the visit can be just really impactful to help them understand that this isn't without harm or some potential side effects, that you should understand when it's best to prescribe an antibiotic and help your patients understand that it's not always the right medication for them. Here's where you can find more information of the core elements of outpatient antibiotic stewardship. You can scan these QR codes. The web version is on your right. The PDF version is on your left there. Patient expectations. I mentioned this a little bit just earlier. Patient expectation can play a role in the overprescribing of antibiotics. If patients are coming in expecting to get an antibiotic, and I know that many of us have had that patient where they're coming in just demanding a antibiotic, and they're not going to leave until they get one. And so clinicians may feel pressured to prescribe, even if it's not clinically indicated. And we see in this small study that patients expecting antibiotics were 3 times more likely to receive them, and clinicians were 10 times more likely to prescribe them if they perceive the patients expected them. And so we'll talk a bit more about this, but clinicians may perceive these expectations even if they're not expressed, especially if we're talking about parents, especially when they're discussing things like what's the treatment plan going to be? How are you going to help little Johnny or little Susie? Many of us and many clinicians may perceive this as an expectation for an antibiotic. But as I mentioned, when clinicians explain why antibiotics are inappropriate, patients and their families are much more willing to forego them. So again, I think the take-home message on this slide is that clinicians have an obligation, and should really talk to their patients about why antibiotics are not appropriate and not the best choice for them. How do you counsel patients, explaining why antibiotics are not needed? The example here is this is a nasty virus, and antibiotics won't make you any better, any faster. Positive treatment recommendations, really honing in on understanding that there are things that you can do other than antibiotics to help you feel better, really explaining that those are some of the great alternatives. Have a contingency plan. If you're not better in a few days, give us a call or come back in. And then one of the tactics I really like is a delayed prescription, right? If you have a virus that run its course, you have 5 to 10 days after this visit. If you're not any better, we'll use that watchful waiting period. And if you're not any better, this delayed prescription can be deployed. And it's very, very effective in reassuring the patient that you are actually listening to them, but also providing the right counseling at the right time. And again, I mentioned this delayed prescription reduces antibiotic use by anywhere from 23% to 75%. In this one meta-analysis of 13 studies, including 9 randomized clinical trials, symptom severity among patients who received no delayed or no immediate antibiotics. So it was similar. You see that symptom severity didn't change. The duration of the symptoms for delayed antibiotics or prescriptions didn't really change as well, right? So the impact of a delayed prescription solution works very well and really doesn't create any undue harm for the patients. And that's the take-home part of this slide here. Other evidence-based tactics to use to help is to watch the labels, refer to cough as a chest cold rather than bronchitis. When patients, in my experience, hear the word bronchitis, it's a big word, and it may be confusing, and it may also bring them to that spot that they say, hey, I'm going to need something for this, like an antibiotic. So in a study of 400 adults, when the term chest cold was associated with less frequent belief in antibiotic therapy was necessary to get better versus, you see this 11% versus 44%. Other things that you can do and other evidence-based tactics is make public comment, posters in exam rooms, understanding that there's a commitment to antibiotic stewardship and that we will appropriately use antibiotics where necessary. Those are clear indicators of the practice philosophy, and communicating that up front with patients can be incredibly helpful in order to avoid overprescribing of antibiotics. So back to you, Rachel.
Thank you, Dr. Watkins. Okay, so we saw this question previously, so let's look at it again. Okay, so spot the lie here. What is the incorrect statement? A, about 20% of patients with acute respiratory infections during flu season received an antibiotic prescription. B, over 2.8 million people have affected, or sorry, I keep saying have, are affected by antibiotic resistant infections in the US each year. Or C, antibiotic resistant infections lead to at least 35,000 deaths per year in the United States. Take a moment to answer that, and I promise this is your last two truths and a lie question. We will revisit those questions from the very beginning very soon. And again, please submit your questions for the Q&A. Okay, so let's see how you did in our pretest for this. So 53% of you said A, about 20% of patients. And let's see how you did in the post-test. We see an increase, about 82% said choice A. Dr. Watkins, what is the lie here?
Yeah, the lie is A, right? So it's half of antibiotics prescribed in the United States are for viral respiratory tract infections. B and C are true answers. So good job there, class.
Thanks, everyone. Okay, so before we get to our last couple questions and our Q&A, Dr. Watkins is just going to go through the key takeaways.
And so this is really helpful. And the key takeaways here: annual flu vaccination is the most effective way to reduce flu risk. And Dr. Auwaerter was spot on when he mentioned, although we're in the second week of January, it's never too late to get your flu vaccine. Antiviral treatment within 48 hours of onset can reduce flu severity, duration, and risk of complications. For severe influenza, oseltamivir may improve outcomes if used for up to 5 days. Baloxavir has FDA indications for influenza, including high-risk patients, and chemoprophylaxis, the single-dose treatment for people 5 years and older. It has similar efficacy with fewer adverse events than oseltamivir. So inappropriate use of antibiotics contributes to 35,000 deaths in the U.S. each year. So understanding that the appropriate use of antibiotics is something that we should all be mindful of. And then again, if you haven't gotten your flu vaccination at this point, it's not too late to go ahead and get it. Thank you, Rachel.
Thanks, Dr. Watkins. Yeah, definitely not too late. So hope you've gotten your flu vaccine and you encourage your patients to do so. Okay, so let's look at those questions again. I won't read the entire thing. We saw this is our first question. So let's get that up for all of you in a poll. Okay, so here's our question about our patient, Marco. I will just read the last sentence in that little paragraph, large paragraph. So Marco did not receive a flu vaccine this year. Is a flu antiviral recommended for Marco and why? So A, not recommended as more than 48 hours have elapsed since its symptom onset. B, recommended if flu is confirmed by molecular test. C, recommended since he has not received a current vaccine for flu. Or D, recommended as high-risk condition for severe influenza. Give everyone a moment to answer that. I know this is a long one. And we, again, will see how we did at the beginning and how we are doing at the end. And I know we're close to an hour, so thank you for sticking with us. We do want to get to that Q&A, so I know our faculty was gracious enough to stay a little late. So thank all of you as well. When it gets to your questions. Okay, so let's see how we did. So most of you said D, recommended, as he has a high risk condition for severe influenza. About 43% of you said choice D. Let's see how you did in the post. Okay, 66% of you said choice D. Dr. Auwaerter, what is the correct answer here?
Well, they certainly were absolutely correct. This gentleman, Marco, has diabetes, and even though he's beyond 48 hours, uh, the suggestion is to still take antivirals because of the high risk for progression. So the other answers were not correct.
Thanks, Dr. Auwaerter. Okay, so let's go to our last, very, very last question. Okay, you all saw this before, and let's administer the poll. Okay, this is our 68-year-old woman confirmed to have flu. She visits the urgent care center. She's brought her 4-year-old grandchild who has asthma, has been hospitalized times this year, has not received the flu vaccine. So, in addition to recommending the flu vaccine, which of the following would be recommended for the child? A, baloxavir, B, oseltamivir, C, peramivir, or D, zanamivir? Give everyone a moment to answer that one. Okay, let's see how we did at the very beginning. So 62% of you said B, oseltamivir, and let's see how you did now. Interesting. 57% of you said B, oseltamivir. Dr. Auwaerter, what are we thinking?
Yeah, so this one is a 4-year-old girl with asthma, and perhaps we confused you a bit during the lecture, but the only drug that FDA approved in this age range is oseltamivir. So those of you that said that one got it correct. Patient has asthma, so you don't want to use zanamivir. You don't want to use peramivir because of the intravenous nature, and baloxavir is only approved for those 5 and older.
Thanks, Dr. Auwaerter, for clearing that up. But I'm sure we'll get 100% at the 30-day survey that we send all of you. So no worries. All right, so questions are coming in. Again, thank you all so much for staying. And just as a reminder, slides will be emailed to you and a link to the evaluation. You must be logged into your DKB Med account in order to access that, and you can claim your credit for your time today. Okay, so Q&A. First question. What are your thoughts on antiviral treatment for patients with comorbidities who are exposed to influenza exposure in home but do not have symptoms?
Maybe I'll take that one first, Rachel.
Okay.
So in this case, if someone's been immunized, I wouldn't necessarily prescribe anything unless they really are not expected to respond to the vaccine. So those may be some of the severely immunosuppressed patients, for example. Otherwise, if you have someone unimmunized and they are exposed, and especially if you have the advanced age patients or patients with significant comorbidities, I think it's very reasonable to consider antiviral therapy. You saw in the baloxavir mini-stone trial, at least, that there was a nearly 14% incidence of getting pneumonia, and that was reduced to 2%.
All right. Thanks, Dr. Auwaerter. Another question. Do you recommend booster doses of the flu vaccine later in the season for immunocompromised people who received their vaccine early in the season? Dr. Watkins, you want to take that one?
Yeah, it's an interesting question. You know that there was recent comment from the CDC of are we getting your influenza vaccine too early in the season? So, folks you may see signs available influenza vaccine, and it's still hot outside, right? It's late August, September, but we don't have a recommendation for these booster doses that I'm aware of. Dr. Atwater, I haven't heard of that, but for immunocompromised folks, that they would still be in phase to receive more clinically indicated the vaccine at the appropriate time. And I always recommend our teams remind their patients to get a influenza vaccine definitely before Halloween.
Yeah, I think you're exactly right, Mark. The CDC has no recommendations for taking boosters. The vaccine tends to be most effective for 3 to 4 months after immunization. So again, I think optimal timing, if you really want that, is October to early November, exactly as you said. So getting it very early, if someone is at high risk, may be problematic because when you need it in January or February, it may not be quite as effective. So but on the other hand, I want to be very clear. If someone presents to you in your office, that's the opportunity to give the flu shot. So you don't want to pass that up. It's better getting it than not getting it at all, which is typically the case there. But boosters are not recommended.
Thank you both. We have another question. Do we know yet how effective the flu vaccine is this season?
We think it's for those that are between the ages of 18 and 64, that it's those who actually received the vaccine were 23% less likely to be hospitalized with influenza. I know that the number goes up for those who are older than 65, upwards of 45% are less likely to be hospitalized. So that's a pretty good number. If you ask me, I'm not sure if Dr. Auwaerter, Paul, would like to add anything to that.
Yeah, I just saw some information before the holidays, so I haven't seen anything more recently, but it looked like the circulating virus was a good match with the vaccine. So whether that will still hold up as the season progresses, stay tuned. But so far, it looked like it's a reasonable match.
Right.
Okay, and we have one last question. So that question is, when writing an antibiotic prescription for someone to hold, how do you indicate an expiration date for the prescription?
So I think what you're describing is if you're going to have a delayed prescription, I think the easiest way to do that is that you can annotate that in a chart and then have them call your office or call the clinic and release it at that time. Sometimes writing a delayed prescription, you may run the risk of someone just filling it at that point with a valid prescription. That would be my recommendation. Happy to hear from Paul if he has any other suggestions.
No, I think that's right. Sometimes the delayed prescription, I honestly just have them call back as sort of my approach.
Right.
Because I think if someone truly needs an antibacterial, I'd rather reevaluate them rather than give them a standby one. I mean, there's always extenuating circumstances.
Correct.
That's my strategy.
All right. I think that was our last question. Well, I want to thank our faculty, Dr. Auwaerter and Dr. Watkins. It's really been a pleasure working with both of you. Dr. Auwaerter and I did one of these earlier in the season, so it's interesting to hear how things kind of changed after the holidays. So everyone that watched, thank you so much. Again, please click the link to take the evaluation to claim your credit, and be on the lookout for that 30-day survey that you'll receive the email as well. You'll also get an email with a link to download a PDF of the slides. Thank you both so much for being here, Dr. Auwaerter and Dr. Watkins. Appreciate your time today.
Yeah, very good. Thanks so much for listening. Have a great evening.
Hello again. This webcast was recorded in January 2024. But we recently chatted with Dr. Auwaerter to give updates on the 2024-2025 flu season. This special update was recorded in October 2024. Before I turn it over to Dr. Auwaerter, please remember to complete the evaluation to claim your CE credit. You can click on that claim credit button. And here's Dr. Auwaerter.
Hello, and I'm here with an update for the 2024 and 2025 flu season. So in this brief update, a couple of things have transpired over the last year. As usual, we take a look at the Southern Hemisphere during the summer, which is their winter, and where the vaccine that typically is used for seasonal influenza here in North America is trialed during that season. Unfortunately, the true vaccine efficacy, meaning prevention of infection, was not was on the lower end of the usual spectrum at 34.5%. So we'll have to see this year how it handles. Now, again, vaccine effectiveness doesn't mean that it is not helpful. People still get the flu, but for those most at risk, they don't get as severe a case of influenza or be at risk of death to the same degree as if they weren't immunized. Also different for this year is that all available vaccines are trivalent instead of quadrivalent. What's been dropped is one of the influenza B lineages that have not been circulating. And there's also a new approved nasal vaccine that can be self-administered, so you don't necessarily have to go to a physician's office. So especially for patients that are needle phobic or so on, or have logistical issues, this may be helpful. Any vaccine is acceptable, but if there is vaccine available for high-risk patients, 65 and over, or organ transplant patients, you can use the high dose or the adjuvanted influenza vaccine that tends to give higher influenza titers and offer more protection. Also new this year is a rapid antigen test that detects not only COVID-19, as we've all been used to during the pandemic, but also influenza A and B. And that complements what has been available over the counter starting last year for a molecular home test, which is a little more expensive, but obviously more sensitive and more specific. So there are some options that patients could find on their drugstore shelves for at-home testing. I do want to bring up influenza prophylaxis, especially in households that might have very high-risk patients, someone who might have active cancer, be highly immune suppressed, or solid organ transplantation, or be unable to mount vaccine response due to medications. FDA did approve baloxavir, an anti-influenza drug, based on a 2020 published article in the New England Journal, which showed that by giving baloxavir to household contacts, it was very effective, reducing the chance of influenza by 86%. Now, reanalysis of that trial, which included an oseltamivir arm, found that oseltamivir also worked, but baloxavir was more effective, about 40% or more effective than the neuraminidase inhibitor in terms of preventing influenza infection. So for me, at least, I would tend to use baloxavir in household prophylaxis if feasible for people that I was highly concerned about in terms of acquiring influenza. Lastly, I'd like to just finish up with avian influenza. This has been in the news quite recently, and it spread not only to various poultry farms throughout the United States in 2024, as you can see here, but also dairy cattle in a number of states. And so this is a virus that we've known about since the late 1990s globally, but now has been present in most flocks described in the United States. But look at this right-hand slide. If you take a moment and study the legend, this virus infects many, many types of mammals, including marine mammals, polar bears, skunks, raccoons, squirrels. It's really been remarkable how widespread this virus is circulating. Now, the good news is that at least at the moment, these H5 and currently N1 avian influenza don't appear to have acquired the necessary elements to make it highly transmissible among humans. In fact, there's not been a clear-cut case of human-to-human spread, although there have been some suggestions, and most have been in direct contact with either infected poultry, birds, or cattle. And now in the United States to date, the number of cases that have been described have generally been mild. That's not been the case historically, mainly in Southeast Asia and Asia, where people live with the animals. Younger people have gotten infected with a significant mortality up to 50%. So far, we've not seen that. And indeed, screening in the United States among workers find that there's very little apparent immunity to the viruses, which means that people haven't been exposed. That's in a way a concern if it ever becomes transmissible among humans, but on the other hand, also is reassuring that there's not undetected activity, and people are also doing wastewater surveillance for this reason. Just who should you suspect avian influenza? Unlike seasonal influenza, this, at least in the United States so far, has been more mild with just upper respiratory symptoms, often with GI issues. Severe disease can cause a significant pneumonitis or even hemorrhage. What has been unusual are cases which have significant conjunctivitis, and this is unusual here for influenza, which typically we think of this more with other viruses like adenovirus. Diagnosis should be suspected if you travel abroad, especially if you contact with birds or other animals, or if you have poultry workers or people interacting with dairy cattle and so on. Please think about that. You can send it for testing at Hopkins. We do assess it in our own virology lab, but probably most physicians would want to send either a nasopharyngeal conjunctival swab to their state or local health department. And there's also serology available. So something to keep watch on. Certainly public health people have been keeping watch on. We'll see how the seasonal influenza season goes, but we do have some home options as well. But hope everyone stays safe and well for the season. And thanks so much for listening.